tutorial situation that is actually happening. Let me actually just check, because Dr. Ndlovu actually sends us these things where he's like, these are tutorials that need to be covered by consultants, registrars, etc. And I'm looking at this, I'm like, able postmenopausal bleeding. I see here fibroids. I see here hypertensive disorders that I even covered for a good 3 hours and 30 minutes with the 5th years. I'm seeing postpartum hemorrhage by Masemula on the 10th of October. Hey, busy. Let me check again. There's so many things. And then I appear with hyperemesis gravidarum. Hey, it's very busy. And then also again on the 5th of the 11th, 5th of November, there's another tutorial again with Songabao with fibroids. Chauke, actually, Tebucho, I'm listening. You guys must are having these tutorials with other people, or are scheduled to have these tutorials with other people. So explain to me.
Yes, doctor. May you please re-ask the question?
That these tutorials will be covered or are scheduled to be covered by other people, including consultants. Now I'm asking when I'm here exhausted after a day of theater where I left the hospital at 6:30 to 7, and I'm here making noise. Yet again, some of these tutorials either have been covered or are going to be covered. Do you want to explain to me?
Yes,
Or do
doctor.
you want to advise me of how I need to proceed in the future?
H Doc, let me start off by saying that we do appreciate having these tutorials with you. The problem that we have been facing for the past few weeks is that times the doctors we're scheduled to have tutorials with are often not available, so we haven't been able to cover a fair amount of them. So these
Mm,
tutorials that we have with you are very helpful on that front in helping us, fill that gap that they've left empty.
understood.
Yes,
But
yes.
I'm
So
sure you've covered hypertension, right, in the unit.
yes, we have covered
But
it
then
with
yet
you.
again, I find myself talking on hypertension for 3 hours. Sort of like I'm having a revisitation of what you've been taught already.
Yes.
Ndwandwe, do you want to comment?
Yes, Doc. I think what Harametso has said is quite crucial and true. The tutorials that we were supposed to have, most of them they've been postponed. So,
Hey, I crucial. Continue.
so we learn a lot from you giving us these stats, and also sometimes even the way of putting information is sometimes different. You see, hearing different, not views, but hearing. Okay, no. Thank you.
What's wrong? Hey, Sukumani, I'm listening. Sukumani. Yes, Kinelwe.
Thank you, Doctor. I think what Ndwanda is trying to say is that if maybe yes, we might have gotten a hypertensive tart, but it might not be as clear as you put it. So honestly speaking, I think even if some of them we redo them with you, it's very helpful and we learn a lot from you. So we don't have to change any the way we approach this.
Ramarumo, Uring.
Naked doctor, let's continue with the task because you see with this ones in the morning, it's only 1 hour. So they don't put too much emphasis on certain aspects. Like now with the CA civics, the only thing that we did in class was the importance of cervical screening, like the vaccination and not screening and treatment. That's the only thing we did. It's only now that we're covering it in detail. So nice say I'll continue.
Whoa, I comrade. Um, okay, let's quickly cover fibroids. I think I'll be able to cover this topic within 2 seconds, but let's see how far we can go so that I can actually go and sleep. Maybe what I can do is that I can just do an overview now, and then after that, I think maybe later on we can actually discuss the treatment. So let me actually share the screen because I'm only gonna talk about fibroids actually using a picture. Um, so also the classification is also important. So what you guys need to understand that is a fibroid is actually just like a growth. It's benign. It's a tumor. So it's a benign tumor that actually involves the myometrium. So the myometrium is actually made of smooth muscle. So now a fibroid is a tumor that when you remove it, the histopathologist is going to comment and say, I'm finding smooth muscle cells, and also I'm finding fibroblasts. So fibroblasts in the myometrium that are interlaced within smooth muscle cells. So it's a benign tumor arising from the smooth muscles that has fibroblasts in it. So if one wants to define it, it is benign tumors arising from smooth muscle cells and fibroblasts of the myometrium. The myometrium is made of smooth muscle cells. So it's benign tumors arising from the smooth muscle cells and also the fibroblasts, which are fibrous cells of the myometrium. They are there in the reproductive age of females, and they may occur. So anyone who's reproductive or has the potential of producing a baby, they are there. And they may have either adverse outcomes in pregnancy, or actually they may cause infertility. So those that have been associated with infertility are those that are closely lined within the endometrium. What am I actually talking about? These are the ones that are that distort the endometrium for the attachment of the embryo. So with that being said, those are your type 0, which are pedunculated intracavitary, or it can be, again, still submucosal, but less than 50% intramural. So this is a very easy classification for you to actually get. Just know that submucosal, it's this part. They are talking about the endometrium. Intramural, they are talking about those within the smooth muscle, meaning within the muscle cell. Or they can be subserosal, which is the outer layer of the uterus, which is serosal. So submucosal, you know very well that number 1, 0, it's submucosal, intracavitary. And then the other one is submucosal, but less than 50% of it actually touches the endometrium, or less than 50% actually touches the smooth muscular layer, the myometrium. And then 2, they will still be submucosal, but more than 50% is actually intramural. Now, however, 3 is purely intramural, but however, it contacts the endometrium. So it touches the endometrium. So the intramural ones are 3, meaning it's within the myometrial layer, but they touch the endometrium. And then number 4, it's completely, meaning 100% intramural. You understand? It doesn't touch, it doesn't do anything. But also, again, number 3 is mainly found in the intramural part, or rather within the muscle. But however, it touches the endometrium. And then number 5, these ones now are also intramural. So more than 50% of it is intramural. But however, there's a component of it that is subserosal. So majority of it is still within the myometrial layer, but it contacts the subserosal layer. So those that are found to be intramural are 3, 4, and 5. And then those that are strictly subserosal are those that are 6, where more than 50% of it or less than, so subserosal, meaning less than 50% of it is found in the subserosal layer. But however, I'm actually now explaining the other way around. Let me actually look at another one that I actually find easier to explain. But now ResearchGate won't actually put me in because now there's a security check-in. But just to actually highlight something, this picture usually comes out in slides. So let me try and explain it better in terms of the fibroids. Let's try and see this. So as I said in the beginning, submucosal, it's your 1, 2, it's your 0, 1, and 2. 0, it's purely in the submucosal layer. When you think of submucosal, you think of the endometrium. Endometrium is the part where the embryo actually attaches. So these are the ones that are actually closely related to infertility. So this one definitely is pedunculated. 100% of it is found in the submucosal layer. It does not transverse into the intramural area, which involves the endometrium. So it's purely 100% submucosal, and it may be pedunculated. And a pedunculated fibroid like this that is submucosal may actually be confused with a polyp. That will explain later. Still within the submucosal layer, within the endometrium, you find number 1. Number 1 is the one that is actually submucosal, but less than 50% of it is actually found in the muscle layer. So it's less than 50% intramural. So number 2, it is still submucosal, but more than 50% of it actually extends within the muscle layer, which is then intramural. And then now, number 3, 4, now we are talking about those that are within the muscular layer. So number 3 is within the muscular layer, so it's intramural, right? But it actually contacts the endometrium. So it's 100% intramural, but it does actually contact the submucosal layer or the endometrium. So it contacts the endometrium. Then number 4 is fully found within the muscle layer. It's intramural. Then number 5, it's in the serosal layer, but within the serosal layer, meaning it's here on the outside of the uterus, but it actually contacts the intramural layer more than 50%. So 50% of it is actually found within the intramural area or the muscle layer, Number 6, it is serosal as well, but you find less than 50% of it inside the muscle layer. But then number 7, similar to number 0, it's mainly found only in the subserosal layer and it can be pedunculated. And then 8 is other, where you actually find it outside the uterus, but you may actually find it just in the cervix. And then the hybrid, when you find a single fibroid, that actually not only communicates with the endometrium, not only communicates with the intramural area, but also communicates with the serosal area. That is why now it's called 2 to 5, because now it's one big fibroid, but not only does it contact the endometrium, but it also found in the muscle layer and also found in the subserosal layer. Does anyone have any question pertaining to that classification? Okay. Kinelwe, do you understand the classification?
Yes, Doctor, I do.
So what you need to understand is submucosal, it's your 0, 1, and 2. Submucosal layer, it's 0, it's within the submucosal layer, which is the endometrium, and it's 100% there, and it can be pedunculated. Then with 1, it is still in the submucosal, but then it actually touches. Then 2, more than 50% of it is found there. Then 3, purely in the muscle layer, which is intramural, but touches the endometrium. 4, purely found in the muscle layer. 5, it's in the outside layer. So classify it in your mind in the following way. Submucosal, it's 3 types, which is 0, 1, and 2. And then intramural, it's 2 types, which is 3 and 4. And then subserosal, which is the outside of the uterus, it is then 5, 6, and 7. So that is how you easily are able to actually delineate or actually understand the classification. So now with that being said, let us continue. So now, hybrid, as I said, it's between 2 and 5, where you find a fibroid transversing through all the layers. Not only is it intramural, but it touches the endometrium, but also now extends to the outer part of the uterus. So it's found in about 31%. So 9.2, it's found in about 9.2 per 1,000 women. And then upon that 9.2 per 1,000 women is because 31% of them are Black and actually 9% of them are white. So the incidence rate, it's 9.2 per 1,000 women and 31% are Black and so the risk factors for fibroids, what I want you guys to understand is the following. Although the fibroids are found to respond to estrogen and progesterone, they are not the reason why they actually come about. So the reason why fibroids actually form is unknown, but the theories are there, especially the influence of estrogen and progesterone in how it actually grows and actually multiplies or rather develops, but not necessarily as to they are the main cause of it. So the main cause of it is actually quite unknown, but there are certain theories to say probably it's because of estrogen and or progesterone, because it has been seen through studies that they actually respond, or the fibroid rather responds to them. So the risk factors will include number 1, reproductive or endocrine factors. By that, I just merely mean estrogen and progesterone. Then you are just going to say, although they respond to estrogen and progesterone, they are not responsible for the genesis of the tumors. So they are, the fibroid is influenced by their presence, but it does not mean that actually they cause them. And then parity. So pregnancies, that are one or more beyond 20 weeks actually have a protective factor against fibroids. So in terms of parity, those that have pregnancies that are one or more beyond 20 weeks reduce the risk of fibroids. And then those who are found to be older at first birth reduces the risk of fibroid as compared those with a younger age. And then early menarche, and it's actually associated with the fact that Black people have a tendency of having early menarche in terms of the people who are in the Black population are found to actually have a menarche from the age of 10 years or less. And that is why more Black people are prone to fibroids as compared to white people, is because of estrogen exposure at a very early age. And estrogen does actually cause the fibroids to actually grow when they form. So menarche is actually associated with um, increased early menarche is actually associated with more estrogen count as compared to those that are post-pubertal. So pre-pubertal levels of estrogen, or those that actually go through early menarche, they're found to have more estrogen levels as those actually who go into menarche later, or actually are found to be post-pubertal. So all that estrogen influence actually influences fibroid growth. And because I'm talking about estrogen, definitely hormonal contraception. But however, are you aware that we can still use combined oral contraception to actually treat the abnormal uterine bleeding that is caused by fibroids? So now you're going to ask yourself, but if I'm giving a patient estrogen and estrogen causes an increase in fibroids, am I not causing it to grow in mass? However, only a low dose of contraception, which is less than 35 micrograms, does not cause fibroid growth according to studies. That is why combined oral contraceptives can actually be still used to treat the abnormal uterine bleeding that is actually caused by fibroids. So a lesser dose or low dose of contraceptives, that's why we use combined oral contraceptives, a dose of estrogen combined with progesterone to treat the symptoms of a fibroid pertaining to abnormal uterine bleeding or heavy menstrual bleeding. There still is a space. But however, they have linked to say those who actually take estrogen at an early age, that is between 13 and 16 years, they are those ones that are actually at increased risk of fibroids. So what am I saying? In terms of hormonal contraception, estrogen low dose does not significantly cause an increase in the size of a fibroid. Any dose that is less than 0.35 micrograms can actually be used with a patient who has fibroids to treat their symptoms. However, the increased risk is only there for those who have been exposed to high doses of estrogen between the ages of 13 and 16. Does that make sense, Ramarumo?
Makes sense, doctor.
However, there has been a linkage of a protective factor pertaining to progesterone alone, but the studies have actually shown conflicting, results. Mirana can be used to treat the abnormal uterine bleeding that you find pertaining to fibroids. And actually, Mirana has actually been one of the recommended things that you can use for fibroids. And some studies have also revealed that some fibroids have been found to have shrunk. There's a study that they did in postnatal patients after they've delivered, and then they insert a Mirana, and when they look at the size of the fibroid during pregnancy and then postpartum, And then after a few months postpartum, after having used the Mirena, they've shown that actually the influence of a Mirena, because it's actually progesterone, has actually shrunk the fibroid. In some postmenopausal women, some of the fibroids actually have decreased in size when they were using long-acting progesterone or the medroxyprogesterone depot. But some studies have found that there's not really any credible evidence pertaining to progesterone and the shrink of a fibroid. But some studies strongly believe that there is an association. And then another one is obesity, as I've reflected on the CA cervix lecture, that those people are actually have more endogenous estrogen, hence why now they're actually at a more increased risk to fibroid. There are some things that actually are related to a diet, funny enough. Diet, they actually say increased consumption of beef and red meats, increase the risk of fibroids. Fruit and green leafy vegetables, they actually decrease the risk of fibroids. And then omega-3 fatty acids increase the risk of fibroids. Alcohol increases the risk of fibroids, and smoking reduces the risk of fibroids because of inhibition of aromatase. Aromatase actually is an enzyme that converts androgens, dehydro, dehyd, DH, dehydroepiandrosterone. So that conversion of androgens into estrogens, that is why smoking is actually a protective factor, because aromatase is the enzyme that actually does that conversion. That DHEAS into either estrogens or what's the steroid hormones or testosterone, etc. So decreasing or inhibiting that enzyme, therefore there'll be less estrogen in the circulatory and also in the circulation. Also, again, smoking causes peripheral vasoconstriction or central vasoconstriction, which will then dry out the fibroid, reducing its size. Race or ethnicity, as I said, black people, because black people are more prone to have early menarche, which actually speaks to their prepubertal estradiol levels that actually increases their risk for fibroids. So now, with that being said, when you're talking about prevention, definitely exercise, reduce obesity, and also modifying some of the risk factors like physical activity, etc. Now, how do these fibroids actually present? Then we're going to talk about treatment. I think we can then pause. I'm just going to talk about the clinical manifestations. And then after that, we can pause the tutorial so that we can continue at a later stage, because tomorrow I'm having a long day. So the clinical features of fibroids is that most of them are asymptomatic. And they actually depend on the size and the number and the location. And the symptoms are classified in three broad categories. So every time you actually think of fibroids, always think about these three broad categories. And then if you think about these three broad categories, you will definitely be able to remember most of the things that are actually there, or the other parameters or rather factors that you can mention. So the three broad categories, it's one, heavy or prolonged menstrual bleeding. Number two, bulk-related symptoms. Number three, reproductive dysfunction. Heavy prolonged menstrual bleeding, bulk-related symptoms, and reproductive dysfunction. So under heavy menstrual bleeding, of course, prolonged menses is actually a typical symptom of fibroids. And if it's not prolonged menses and then it's intermenstrual or postmenopausal, you must always think of endometrial pathology. You must always do endometrial sampling. When it comes back, it might be CA endometrium, or it might actually be endometrial hyperplasia. So heavy menstrual prolonged bleeding, Heavy prolonged menstrual bleeding, it's related to menses, nothing else. But if it's now intermenstrual or postmenopausal, which is very important for exam, postmenopausal or intermenstrual, your investigations also need to include an endometrial sample, because that type of bleeding is actually associated with an endometrial pathology. So this heavy menstrual bleeding or prolonged bleeding is associated with iron deficiency anemia. And because of the fibroid, the bleeding is actually caused because of impaired contraction after menstruation. Remember, the shedding of the endometrial lining, the myometrium is supposed to actually now contract. And then after that, the menses actually stop. But because of the fact that the myometrial architecture is distorted by this fibroid, prolonged menses are then going to continue, because at a cellular level, or rather a muscle level, that myometrium is unable to contract because of the distortion, because of the fibroids. Now, when it comes to bulk symptoms, think of a uterus, think of a large fibroid, especially a 6. Imagine this serosal, it impinges on the intramural part, but also has a serosal part, and it's large. So bulk symptoms will include this large irregular shape in terms of the abdomen, or it can be a distended abdomen, and it can cause pelvic pressure or pain. Think about a fibroid in the posterior side of the uterus. Definitely, it's going to cause lower back pain, pelvic or menstrual pain, pelvic pressure, abdominal bloating or abdominal protrusion. But also, again, if it constricts at the back because it's located posteriorly, it may actually cause difficulty in emptying. It may cause constipation or bowel obstruction. If it's anterior, it may cause difficulty emptying the bladder, frequency, or complete urinary obstruction. Or you may not actually even be able to empty the bladder. And then imagine a fibroid now on the fundus, and then it might actually compress the inferior vena cava, increasing the risk for venous thromboembolism, because inferior vena cava, now the vessels that are actually coming up from the legs that drain within the inferior vena cava, now the inferior vena cava is blocked. Now there's that varicose triad, there's stasis, and then there's a formation of a clot. So some people with fibroids may actually be at risk of a VTE, or they may have a TVT. Also, it may cause pain during intercourse. Then, if the fibroid outgrows its blood supply, a patient might actually have an acute breakdown of the fibroid, and that is actually called red degeneration or carneous degeneration. And in a patient who is pregnant and a fibroid undergoes this red degeneration because it actually outgrows its blood supply, a patient in labor or patient who's pregnant might have pain, uterine tenderness, or might have peritoneal signs. This usually responds to Panado. If it doesn't respond, then it might not be it. And your first differential diagnosis for that patient with this tenderness is definitely going to be an abruptio. Does that make sense? Patient.
Yes, makes sense, doctor.
So lastly, in terms of the triad I spoke about, it's infertility or obstetric complications. The submucosal fibroids you may find it difficult to conceive, and also some intramural fibroids that actually also touch the endometrium, like a type 3. um so the intramural that touches the submucosal layer may actually increase the risk for miscarriages, but however, several studies have actually disproved that. You may actually get a large fibroid that may also cause placental, I don't want to say insufficiency, but the layer of the placenta that is actually attached to where the fibroid is, like in a type 3, where it actually touches the endometrium, but however, it's intramural, or in a type 2, where there was actually distortion of the attachment of the placenta in that particular portion, you may actually find some patients even presenting with an abruption or retroplacental clot in that position. If it's a large fibroid that is, let's say, a type 2, that actually occupies the whole of the submucosal portion, or you have a type 0 that actually occupies the submucosal portion, or a type 3 that actually touches, that actually may cause not enough space for the baby to grow, might actually cause fetal growth restriction, or the fibroid in itself, depending on its position, may actually cause malpresentation or even preterm labor or preterm birth. Other issues is that a prolapse fibroid that actually can be seen that can go through the endocervical canal, or can actually go through the cervix itself. They may actually cause an infection or mass or a bleeding, possibly, and also ulceration. When you pass the speculum, you look at this mass that actually has now protruded through the cervix. Now it is also incarcerated and has this possible ulceration and is actually foul smelling. So a pedunculated fibroid actually is a differential diagnosis for a cervical mass. A cervical mass could be either the following: it could be a cervical polyp, it could be a pedunculated fibroid, or it could be a tumor from a CA cervix. So when you are actually getting a case in the exam where they say that you find a tumor in the cervix, it may actually be a case that's leading you to fibroids, or it may be a case that's leading you towards a CA cervix. Does that make sense? So I think we can actually close off from here, and then we'll actually talk about the management and how do you actually diagnose the fibroids. Any questions? So that will cover soon. I don't know when, but that part will be able to cover. Any questions, Tabiso? Masingi, any questions?
No questions. So,
Tebogo, any questions?
No questions, doctor.
Ndwandwe, do we understand what's going on?
Yes, doc. No questions. I understand.
Okay, so on the next lesson, we'll actually talk about how do we then manage fibroids. We're gonna talk about things like hysteroscopic resection, what is the role for saline infusion, sonography, and then how do you diagnose these fibroids? What is the role of MRI to actually check these fibroids? And also, what do we then give? Because it's very important. Why is it important? Fibroids are benign tumors for people who are still within the bearing age. What I want you guys to actually think about is the treatment of fibroids. Because remember, you can't use combined oral contraceptives for someone who wants to get pregnant. And then also, you can't say to me, Dr. Mavata, we're going to be doing myomectomy. Do you know that the complications of myomectomy could also include a TAH? While you're trying to remove that fibroid, the patient can actually bleed. But however, most of the treatment modalities that are actually available for people with fibroids, especially those who desire future fertility, includes GnRH analogs, But now the GnRH analogs, they actually cause amenorrhea. And actually, those people actually will not release an egg. It blocks ovulation. So, what treatment modalities are actually there for patients who desire future fertility, but then, however, they can't do contraceptives, they can't do Mirena, they can't do GnRH analogs? Tebuho, have you thought about that?
Yes, doctor.
Have you thought about that concept? Or am I confusing you?
Mm, not really, doc. No, I wouldn't say that you're confusing me.
Oh, but you understand
Mm.
the things that we still need to discuss.
Yes, I understand the things that we still need to cover.
Maputu,
Yes, doctor, I
you
understand.
understand what I'm talking about?
Yes.
Because most of the treatment for fibroids, it's combined oral contraceptives, it's oral contraceptives, estrogen, progesterone, but all those actually um, block people from getting pregnant. So now what about those who actually desire future fertility? You can't be giving them Zoladex because Zoladex actually prevents pregnancy. Combined oral contraceptives actually prevent pregnancy. Now we need to be discussing what modalities are available for people to control the symptoms of fibroids, but they still desire fertility, but not without actually going in for a myomectomy. Does anyone have any idea what these modalities could be? Diale?
Dog, I did not get the question.
Patient still desires fertility, but you cannot give them Zoladex, GnRH analogs. You cannot give them contraceptives to control the heavy menstrual bleeding. You can't do a myomectomy. What other treatment modalities are actually there so that this patient actually is relieved of their symptoms of a fibroid, but still can get pregnant?
One will maybe consider uterine artery embolization, maybe.
That's one of them. And then what else?
Magnetic resonance guided focused ultrasound
That's
surgery.
one of, okay. Yeah, that's one of them.
I'm not sure what else, Doc.
But what is number one? Out of all these things that you've mentioned, what is the top tier? If someone can answer this, I'll be impressed. What is the top tier in terms of management of fibroids without going to theater and removing the whole fibroid, doing the myomectomy? What is the gold standard pertaining to the management of fibroids without doing a myomectomy and without doing the MGRFUS or the HIFU? So those are the things that we actually need to discuss. There's a lot. So now we'll go through the fibroids, but all I'm saying is that fibroids, you need to define your management to those who desire fertility, which means all your contraceptives are off. And then those who do not desire fertility anymore, then what treatment modalities are there for them? So that's exactly what we are going to discuss. We've discussed some epidemiology in terms of the fibroids. We did say 9.2 per thousand women, and then we said about 31% is black, and then about 8-9%, I think, is about the white people. And then we said these are the symptoms that they actually present with. And then we spoke about the three cardinal symptoms: heavy menstrual bleeding, pelvic or pressure symptoms. And then the last one is the adverse pregnancy outcomes, where we actually spoke about preterm labor, rupture, fetal growth restriction. It may cause miscarriages, but there's really less studies, or there's a paucity of data, rather, not enough data that actually prove that it's true. Then we also spoke about the risk factors, early exposure to estrogens, and then we also spoke about the parity involved in that. We also spoke about some elements of diet. So as I said in the beginning, it's just benign tumors. Now we need to understand, how do we treat them with those that are desiring fertility and those that do not. I think we can close off the tutorial for now so that we can all get go to sleep. You guys are doing clinic tomorrow, and I also have a very busy clinic. So I think we'll talk. Goodbye, everyone.
Good night, Doctor.
Thank you, doctor. Good night.